Good morning, thank you, Mala. Keratoconus. Keratoconus ගැන අහලා තියෙන කට්ටිය කවුද මෙතන? අහලා තියෙන කට්ටිය පොඩ්ඩක් අත උස්සන්න බලන්න. හරි, ඔක්කොම අහලා තියෙනවා. Keratoconus patients ලගේ මේ refractions එම කරපු කට්ටිය කවුද? ඔක්කොම ලගේ කරලා තියෙනවා. So what I want to do is after this lecture, I don't want you to miss any patients of keratoconus because this is a very serious condition if it is not treated early, because previously we didn't have many other treatment options, so we only gave glasses or contact lenses. But now we have various treatment options, and if we miss these keratoconus patients, we are doing a great harm because most of these patients are young patients. ගොඩක් කට්ටිය අපිට එන්නේ less than 20 years. මම හිතන්නේ මගේ මේ කියන්නේ වයස අඩුම එක්කෙනා 8 years වගේ තිබ්බා. ගොඩක් කට්ටිය 12, 13, 14 less than 20 years කට්ටිය තමයි එන්නේ. It's progressive. That is, it doesn't stop until the age of about 30 to 40 years. It keeps on progressing, and usually one eye starts early, and then it goes to the other eye. So what they say is 50% of a normal eye will progress to keratoconus over the next 16 years. We don't know the cause. අපි cause එක හරියටම දන්නේ නැහැ. හැබැයි there are various factors like genetic or environmental. But one of the main features of keratoconus is eye rubbing. So one of the main advice that we give the patients is don't rub the eye. And there are various associations like Downs, Turners, Marfan's, things like that. And keep in mind, after corneal transplant, the chance of that patient getting keratoconus again is very rare. So in my practice, I have never come across a patient who got a transplant and got keratoconus after that. So these are some of the various ocular associations. And patients with asthma and eczema have a higher chance because they have an allergy and they keep on rubbing the eye. So what we don't know is whether the itching causes the eye rubbing and causes keratoconus, or the keratoconus causes eye rubbing and causes the itching. But either way, we should ask the patients not to rub or scratch the eye, and we should give them the treatment. Cornea has 5 layers: epithelium, Bowman's, stroma, and decimus and endothelium. How do you get the pointer? Pointer? Okay. So this is the cornea, and the main areas of changes are in the Bowman's layer and the stroma. And ultimately, if this is not treated, it can go into folds in the decimus membrane. So if you can see, this is a normal cornea, and this is a keratoconus with various stages of scarring. Like I said, they present during puberty, and usually they come with poor vision, usually in one eye. And when you do a refraction, sometimes or most of the time they will get 6/6 vision, but they almost always have a cylindrical power. And after some time, they come back again after 3 months, 4 months, 5 months, because their vision has changed. If you can notice, sometimes now their vision will not get corrected to 6/6 or 6/9, and their cylindrical power is also increasing. At this point, you should have in your mind, are we dealing with a patient with keratoconus? And if they are wearing contact lenses, they will be less tolerant to wear contact lenses. So the hallmark of keratoconus, there is central and paracentral stromal thinning. Like I said, the stromal part gets affected. There's what is called apical protrusion, irregular astigmatism. So these are the signs of keratoconus. I think you would have seen this, what is called the oil droplet reflex. I'll go into the other signs in a little while: the Vogt stripe, prominent corneal nerves, Fleischer's ring, Munson's sign, and what is called acute eye drops. Like keratoconus, kerato means cornea, conus means conical shape. The cornea becomes conical shape. So if you can see, the cornea becomes a cone-shaped structure. So this is the main feature of keratoconus. and there is thinning. So if you can see this area, the cornea is quite thick, but when it comes to the apical portion, it becomes thin. So this is the changes that occur in the cornea. And this is a patient who has advanced keratoconus in the right eye and a form of a early keratoconus in the left eye. And if you have a slit lamp and if you use a slit beam, you can see this. So the upper part and the lower part will have a sort of a thickness. The inferior or the apical part will have a thinning area. And these are what is called the walk striae. If you look at the slit lamp, you can see this vertical striae that is there in the cornea. And another useful sign is what is called the Fleischer's ring. Fleischer's ring is a brownish circular discoloration of the cornea. This also gives a pathognomic feature of keratoconus. So again, the Fleischer's ring and the walk striae. What they say is with walk striae, if you press on the cornea and you release it, the walk striae disappears. So these are not permanent features of a keratoconus, but this just shows that the cornea has become thin. And another useful thing is if you put a torch on the side, you can see that there's a sort of a pointed image that is seen in the cornea. Otherwise, it will be a sort of a circular image. But with keratoconus patients, they have a sort of a pointed image, and it is called the Rutschke's sign. And another useful one is what is called the Munson's sign. So because there is a protrusion, if you are the patient to look down, you will see that there is bulging of the lower lid, which is called the Munson's sign. And I think most of you have seen this oil droplet reflex in the ophthalmoscope. So there's something like a oval or a circular shape that is seen, which is called the oil droplet sign. And you cannot miss this kind of a, can I have the video, which is called the scissor reflex. Video, can you get the video to play? It's not playing. Anyway, so scissor reflex, I think most of you have seen in the retinoscope. So there is a abnormal motion of the pupil. Just check whether that. It's okay. Not come. Yes, sir. Come on. So I think yeah. So this is the scissor reflex. So keep in mind when you have a look at a patient and you see this reflex, you are dealing with a patient who has keratoconus. So how do you evaluate? So evaluation is refraction keratometry. And those two are the basic things, and everyone has access to those things, the refraction and the keratometry. You can go into the higher levels of investigations like computerized video keratographies, placido-based tomography, pachymetry, OP scan, and pentacam. But keep in mind, you don't have to have these to diagnose keratoconus. This is an important slide because this is how we grade the keratoconus. We can have mild, moderate, and severe keratoconus. If the keratoconus value is less than 48, we call it mild. 40 to 54 is moderate, and more than 54 diopters is a severe keratoconus. And we have a grading system, severity 1, 2, 3, 4, which is the Crumb classification. And that we take into account the thickness of the cornea, spherical equivalent, and changes in the cornea. So corneal topography is an AC method of detecting early keratoconus, and we can also monitor the progression. Before knowing what an abnormal cornea is, we have to know what a normal cornea looks like. So usually around 99% of the K value is between 39 to 48. And this is smooth color map, where the color is not deviating, and usually it is green in color or slightly yellow. And as you know, the cornea is thicker in the center and flatter towards the periphery, which is shown in the color map. And if there are changes, usually they will mirror the two eyes. The changes that are there in the cornea will mirror. That means the mirror structure, if it is mirroring, usually it is not keratoconus. So, and also you can have what is called a bow tie appearance. So these are called bow tie appearances. So this is a bow tie appearance. So this is what is called a with the rule astigmatism, and these are against the rule astigmatism. But these are also not keratoconus. So like I said, this is a normal picture of a topograph. And if you can see here, this is an inferior steepening. The superior is on steepen, inferior steepening, and this is a picture of a keratoconus. But here, this is what I said, a mirror image. So if it's like a mirror image, the two eyes, this is not keratoconus, this is with the rule astigmatism. And if you don't diagnose and if the treatment is not started, you can go into what is called acute hydrops. That means there's rupture in the decimus membrane, then there's aqueous which comes in the stroma and causes the cornea to swell. And after some time, they can cause scarring and they can cause vision loss. So we can prevent these patients from going to acute hydrops if you start treatment early. The differential diagnosis of keratoconus, I won't go into detail, but usually it's keratoconus, pericyte marginal degeneration, keratoglobus, and posterior keratoconus. So keratoconus, you have this inferior steepening. Pericyte marginal degeneration is the nasal and the temporal corneas that are affected. Keratoglobus, the entire cornea, and posterior keratoconus is only the posterior part of the cornea is affected. Treatment, most of you know what the treatment is. Usually when they come with poor vision, we give them glasses, and if they feel that they are not happy with glasses, we can go into contact lenses. But keep in mind, any power more than 4 diopters, the child or the patient will not tolerate. So then you have to go for contact lenses, and sometimes this is the patient's preference. If they can afford and if they want clear vision, they can go in for contact lenses. I will speak about it in a little while. We have what we call intacs. We don't do it in Sri Lanka, but we had an option of treating them with intacs. These are PMMA arcs which are implanted into the cornea. So we have what is called collagen cross-linking. So why I told that it is important to detect them early is the earlier you do collagen cross-linking, the better the prognosis for the child. What it does is it stops the progression of keratoconus. Glasses, contacts, and intacs, they did not stop the progression, but just gave them good vision. But cross-linking, they halt the progression. So what we do is we have riboflavin eye drops, we put it into the cornea, and then we do a laser treatment using ultraviolet light. What it says is it stabilizes the cornea, and it increases the biomechanical stability of the cornea and reduces the degradation of the cornea. And it also prevents digestion of the corneal proteins. So this is the surgical technique. What we do is we have to take what is called epi off. So we take the epithelium off, we use 20% alcohol, we then wash it off, and then with a spatula we take the epithelium away. So the epithelium is taken off, and then we apply the riboflavin drop every 2 minutes for 30 minutes. And after that we apply the ultraviolet light for 5 minutes. We have certain protocols, we follow the Dresden protocol, and with the irradiation we can change the time, but usually we use it for 5 minutes and then we put a contact lens over it. So it's very important that we focus it when we are doing it, otherwise the defocus can lead to loss of the success rate. After cross-linking, we put antibiotic eye drops, we have bandage contact lens, we use artificial tears for about 3 to 6 months and steroids for about 2 weeks. So it's very advantageous because it's an outdoor procedure, OPD procedure, day case, they can go back home the same day. because we take the epithelium off, they will have a little bit of vision becoming poorer, but over time it gets better. And you don't need to do corneal transplants with all its complications and problems. So we can do cross-linking and prevent the progression of keratoconus. Like I said, what they tell is the bonds between the cornea are improved so that the cornea becomes more stronger and prevents the thinning of the cornea. If this fails, we have to go in for keratoplasty, or we have to go for a corneal transplant. So we do that for patients who are contact lens intolerant. If the contact lens falls, if they don't get good vision with contact lenses, or if there's progressive thinning towards the periphery. There are two types. We can do what is called a penetrating keratoplasty, where the full thickness of the cornea is grafted. But there is a greater risk for graft rejection. There's post-operative astigmatism, and they need topical steroids long term. These topical steroids can cause cataracts and glaucoma in these patients. Because of these problems, we have gone into what is called deep anterior lamellar keratoplasty, where only the selective layers of the anterior cornea which are affected by keratoconus is transplanted. This is a structurally strong globe, and we need to use steroids only for a short duration. So what we do is we go in for a partial thickness trephination of the cornea, and then we take out that part. What we do is we use air. If I have time, I'll show you a video. We have air, and then we separate the anterior and the posterior part of the cornea. We take that corneal part out, and then we implant the donated cornea into that. So basically, the penetrating and deep anterior lamellar keratoplasty, if we can do a deep anterior lamellar keratoplasty, that is technically better for the patient, but only thing is they might say that sometimes there is a interface haze, but if we can go in for a lamellar keratoplasty, that's the best way. So this is a patient who had a keratoconus. If you can see the thinning and the Vogtstra and the apicus crust, this is a patient after the corneal graft, the deep anterior lamellar keratoplasty. So advantages, like I said, there's minimal risk of rejection. Eye heals faster. There's less risk of cataract and glaucoma because we need to use steroids only for a short period. Disadvantages are it's time consuming. You have to have a learning curve, and you have to have instruments to do it, and lots of possible contrast sensitivity and poor vision. Another thing we have to keep in mind is we have to see patients who have undergone transplants whether they are getting graft rejections. There's epithelial and endothelial rejections. The patient will come with poor vision, halos, photophobia, and redness of the eye or irritation. If any patient who comes with a graft with these signs, you have to keep in mind that the patient might be going for graft rejection. And if so, you have to refer them as soon as possible, because if he starts treatment with steroids, we can get the rejection under control. If not, the patient can go into complete graft failure. And also, you have to keep in mind, because we have sutures, they might come in with loose sutures. So loose sutures also will cause irritations and photophobia, and any patient coming with this, we will have to refer so that we can remove the sutures and resuture if needed. I'll go to the next presentation. So contact lenses. I know almost everyone is very familiar with contact lenses, and we have various ways of using the contact lenses to improve the vision and quality of life. So it is an artificial device which is placed on the cornea for optical, therapeutic, or cosmetic purposes. And if you have something like this, if you have something saying these measurements, 8.9, 13.5, 12.5, what does they mean? Usually what it says is 8.9 is the base curve, 13.5 diameter, and 12.5 is the dioptric power of the contact lens. So what are the ideal material properties? It should be wettable, porosity and permeability, high water content, heat resistant, specific gradient, and scratch resistant. These should be the ideal things that are there in the contact lens for patient comfortability. And oxygen transmissibility is one of the key features which helps us to know whether how the contact lens can be used. So there's a formula, I think you know, dK over L. So D is a diffusion coefficient, K is the solubility of the gas, L is the thickness. And it depends on the permeability of the lens material, thickness of the lens, and temperature at which the test is performed. So currently we have gas permeable, soft, spherical contact lenses and the hybrid contact lenses. Like I said, we use it for therapeutic, for protecting the healing cornea, cosmetic, if the cornea is sort of discolored, and optical purposes for correcting refractive errors. The design is we have spherical, having anterior and posterior spherical surfaces, aspheric like in the cornea, toric where we have two angles at different meridians, bifocal and progressive. If you take a cross section of the contact lens, you have the central anterior curvature, the posterior curvature, the peripheral curvatures and the overall diameter. So this is a cross section of the contact lens. Base curve is one of the key features of a contact lens. It is the radius curvature of the central region of the posterior of the contact lens. And this is important. I will come into that in a little while. So if the contact lens center thickness, it gives us, so if it's the minus lenses, the contact lenses are thinner. And if it's hyperos, the contact lenses are thicker. And smaller diameter lenses are thinner and larger diameter lenses are a little bit thicker. Because these are important for lens fitting. So for comfortable lens fitting, the base curvatures are important and the diameters are important. If you go into the history of contact lens, it was first proposed in 1508 by the great Leonardo da Vinci. And then in 1938, we had the first square contact lenses, PMMA. 48, we had the corneal contact lens. 1950s, we had the soft contact lenses. And in the 1980s, RGB and the soft toric contact lenses. And in the 1990s, we had the silicon or hydrogen contact lenses that were introduced. We can correct any form of ametropia, myopias, hyperopias, astigmatisms, presbyopias, and as well as aphakias. And the thing with contact lenses, they are different from spectacle lenses. So with contact lenses, the hyperopes experience a smaller image than the spectacle equivalent. And the myopes have a larger image. So these are two of the drawbacks of the spectacles, which are overcome in the contact lenses. The myopes see a little bit larger, the hyperopes see a little bit smaller. Apart from the base curve, the tear lens is also one of the key features of the contact lens. So the base curve is, the tear lens is the area between the posterior surface of the contact lens and the anterior surface of the cornea. So if the base curve is equal to the K readings, we have a planar power contact lens. If you have steeper, we have a plus power contact lens, and if it's flatter, we have a minus power tear film. So according to the base curve, we can get a plus or minus contact refractive error correction. And also this is also astigmatisms, how the correction is being done. So even that you can have different angles, and what we do for astigmatism correction is we have a truncated contact lens where the bottom of the contact lens is a little bit bulkier so that the contact lens will not distort or rotate. What about accommodation? Spectacle corrections and accommodations with contact lens are a little bit different. Spectacle wearing myopes accommodate less than contact lens wearers. And in ametropia and contact lenses, it's almost the same. So accommodation demand of a myope is greater in contact lens, and accommodation demand of a hyperope is lesser than a contact lens wearer. Why do a lot of people like contact lenses? Because they have a wider range of vision. The spectacle rim effect is not there. And more importantly, people who are having active lifestyle, they can use the contact lenses more comfortable. And you can use, if the high decay value, you can use it so almost overnight. The disadvantages are you have ghosting figures, and if the contact lens is not fit properly, you can have problems. And I will go into the physiological and the physical problems of contact lens in a little while. We have what is called bandage contact lenses. So patients who have something like corneal edemas or corneal epithelial defects, we can use these bandage contact lenses to get, these are short-term use. Usually you don't use it for more than 2 to 3 months. These do not have to be replaced. You don't have to take it out because this has a high water content and diffusibility. You can keep it overnight, but after about a month or so, you can remove these contact lenses. And you also have these cosmetic contact lenses for people who have corneal scarring. You can use these cosmetic contact lenses. The newer contact lens, what is called the Rose-K or the scleral lenses, we have 5 types: the nipple cone, normal cone, post-graft, irregular cornea, and for severe case of semiscleral contact lenses. So these are some of the hybrid contact lenses which the patients have. So they have, some of these patients are quite happy because these are not as rigid as the RGB contact lenses. And most patients feel that they are comfortable in using these hybrid contact lenses. So like I said, the oxygen diffusibility is the key factor which causes us how long we can use the contact lenses. And we have that terminology. We have daily wear, flexible wear, extended wear, continuous wear. So you have to keep in mind, you have to inform the patient what type, if you are giving contact lens, what type of wear that you should be wearing. And please make it a point to inform them that they should not wear the contact lenses overnight if it's not intended for use to be used overnight. And fitting of the contact lens, there's a difference between the RGB and soft contact lens. RGB contact lens, we have to use fluorescein to see the fitability, but soft contact lens do not use fluorescein because this can stain the contact lens and you will not be able to use the contact lens after that. One of the key factors are the care and maintenance of the contact lenses, and we have to use, depends on the contact the regime and the type of contact lenses, material, lifestyle, and the specific patient needs. As you know, we have to use care solution because the contact lenses are kept in these care solutions because these are used to kill the microorganisms and remove the deposits, keeps the lens hydrated, and conditions lens surface and maintains the compatible with the tear film. Some of the problems when you use contact lenses are mainly hypoxia complications. I will go put some pictures of them. Epithelial microsis, endothelial changes, corneal neovascular hyperemia. So these are corneal striae that you can get, corneal folds, and these are also corneal folds. These are what is called epithelial microsis and microsis. These are negative staining microsis. These are endothelial changes that can occur, and corneal neovascularization. All this can be avoided if the patient uses contact lens in a proper manner and come back to us if they have any problems. The physical problems are lens fitting problems, halos, superior epithelial lesions, and solution hypersensitivity. So if you can see, this is a patient who has a good centration and coverage. This has poor centration. These are superior epithelial defects and staining, fluorescent staining which is there. So these are some of the problems that they can have with contact lens wear. And these are some of the bad sort of very poor prognosis of patients who have contact lenses if they don't use it properly. Microbial keratitis, acanthamoeba keratitis, and ulcers. One of the key things that we have to inform the patients is not to wash the contact lens with running tap water, because sometimes when it falls or something, they use tap water to wash them. You should not do that. And also, if they have any irritation, any pain, any reduced vision in their eyes, remove the contact lens and ask them to see an ophthalmologist or eye surgeon immediately, because that can be a ulcer or an infection that is occurring. So helpful tips, I think these are very important to tell your patients. So like I said, after use, you have to use a contact lens solution and keep the right and the left contact lens in the separate the solutions that they have given. And don't use fingertips because these can scratch the contact lenses. And if you wear makeup, apply it after inserting the contact lens. If you are using hairspray, insert the contact lens and then apply the hairspray. And always remove the contact lens first and then remove the eye makeup to avoid contamination. So what are some of the do's? Like as wash your hands, change your contact lens as recommended, change the contact lens case every 3 months, and have a proper eye examination once every 3 months or 6 months. And don't wear a contact lens longer than recommended. Don't sleep with your contact lenses. And also the contactless solution without asking the provider, don't change the contactless solution, and don't sim with your contact lenses on. Thank you. So this is a video of a patient who had a keratoconus. So what we do, we mark the cornea, and then after we mark the cornea, we try to get the center of the cornea, and then we mark the area that we need to refine. So we use corneal markers. And then after we take a partial, so like I said, there are 5 layers. We take a partial layer off. We take a epithelium and part of the stroma away. Stroma away, and then we just take out the anterior stroma part out. And then what we do is we use a needle. So what we want to do, we use air to separate the decimus layer from the stroma. And then after that, we have what is called a blunt air cannula. We insert it into the pocket that we have made, and then we inject air. So when we inject air, the anterior part gets separated from the posterior part. So this gets separated, and after that we can remove that part. What we do is we leave the healthy decimus and endothelial patient. So we can take the unhealthy keratoconus part away and leave the patient's decimus and endothelial layers. And so this is just taking out some of the anterior part of the area. So if you can see this area, the eye is not open. This area, the eyes, the posterior parts are intact. So what we do is then we get a donated cornea and we refine it, and we have to remove, because we are leaving the patient's epithelium and endothelium, we take out the donated person's epithelium endothelium of is taken out, and this is then put into the patient's eye, and we put sutures, and then this is what is called a deep anterior lamellar keratoplasty. Thank you. Any questions?